Hello, my name is David Castilleja. I'm a student at El Centro College, and today I'm going to be talking about my lateral knee radiograph image analysis. This is for RADR class 1250, and this is a lateral knee that was taken at North Texas Imaging, um, where I currently do my clinical rotations. So let's begin. On March 25th, 2019, bilateral standing knees were ordered for a patient. He was a 64-year-old male, and his relative work history included working as a mailman for well over 35 years. And he came in complaining of symptoms of long periods of pain in both knees, mostly in his left knee. The eventual diagnosis was osteoarthritis in the left knee. These images, like I said, were taken at North Texas Imaging Center in Dallas, Texas, in X-ray room 1. The equipment that was used to take this picture was a Philips DR system. The SID that was used was 40 inches, and the technical factors were a 65 kVp at 5 mass. There were not any breathing instructions, as there normally isn't for knee X-rays, but only to remain as still as possible. The start of the exam began as most others do. I set up the room beforehand if I get a chance to know exactly what X-rays I'm going to be taking. In this case, I saw that they were standing bilateral knees, and so I went ahead and ahead of time set up the room for bilateral standing knees. This consisted of lowering the wall bucky down to the pretty much as low as I could, and then I'll adjust when I see the patient. I'd bring the X-ray tube at 40-inch SID in a horizontal beam and align it with the wall bucky. I then put in the IR in a uh, horizontal orientation, and at that point, I'm ready to go get the patient. So once I do that, I go to the waiting room and pick up our patient, bring him in, and ask him his name and birthday. He gives me both, and I see that it matches what we have on the requisition form. And then at that point, I confirm with him that we're doing standing bilateral knees, and he eventually agrees. And so we go ahead and get ready to get started. In that, I show him how to do the exam instead of just kind of verbally telling him exactly what we're going to do. That way he gets an idea. So what I do is I go to the wall, bucky myself, and stand there and show him exactly what I need. So we have two APs of the left knee and the right knee, and then two laterals of the left knee and the right knee. Without going into specifics, I basically show him exactly how to stand with each leg. I show him where I need his knee to be and how I need it bent once I'm on the lateral parts of the pictures. And he seems to understand, and we go ahead and get all four images the way exactly how we need them to. And this was the one I eventually chose for my paper here and my case study. So to get more into detail about exactly what makes a left knee good, according to Bontrager, the following is required for a good lateral knee, I'm sorry. Distal femur, the proximal tibia and fibula, and patella are shown, which they are here. The patellofemoral and knee joints should be open. Over rotation or under rotation can be determined by identifying the adductor tubercle on the medial condyle, if visible, and by the amount of superimposition on the fibular head by the tibia. True lateral position of the knee without rotation demonstrates posterior borders of the femoral condyles directly superimposed. Patella should be in profile with the patellofemoral joint space open. The 5 to 10 degree cephalad angle of the CR should be result in direct superimposition of the distal borders of the condyles. Knee joint is in the center of the collimated field. The optimal exposure with no motion visualizes important soft tissue detail, including fat pad region, anterior to knee joint, and sharp trabecular markings. So, as far as the picture goes, uh, as far as corrections and things of that nature, the centering on this particular image isn't as ideal as I think it should be. I think I centered a little bit lower. It's evidenced by more than probably a distal 1/3 of the proximal tibia and fibula being shown, and less of the distal femur. So we see more of the tibia and fibula and less of the femur, and that would indicate centering lower than what I probably should have. Another thing that I indicated on my paper that I didn't entirely agree with, or think that could have been better, I should say, were leaving the jeans on during the X-rays. In this particular location, traffic flow is pretty busy, and if we had to ask every patient who we had to do lateral knees and remove their jeans, it would just back up traffic tremendously. And while sometimes that's worth the trade-off at this point, according to the techs that I work with and the radiologist that's present at the location, we don't need necessarily to ask every patient to remove the jeans unless it's absolutely necessary, depending on maybe the texture of their jeans. In this case, they said no, all was good, and we can just go ahead and just do right through jeans. So that's what I went ahead and did. But however, as you can see in the picture, you can see the markings of the jeans, and I think that always, in some manner, one way or another, might interfere with the radiologist's impression of what's exactly going on. And so, if that's another thing I could correct, if possible, that's one thing I would. Um, as far as everything else, the image was eventually considered optimal. The radiologist got the impression of osteoarthritis in the left knee. Uh, so in that case, the image was good enough to be able to warrant a diagnosis, and the that was just about the end of the exam as far as everything that was required and what the radiologist needed to see. As for anatomy in a particular picture, I've labeled a little bit over 10 different parts of anatomy in the left knee that can indicate making it a good picture. Here we have the distal femur right here. We have superimposed medial and lateral condyles, which are pretty good, I would say. There's still slight superimposition here and here, but for the most part, I think it was pretty good at superimpositioning. The base of the patella is here, and here's the apex. This is an open joint space here, more open joint space here. It's called the intercondylar eminence. The apex of the head of the fibula is right here. The head of the fibula is here. The neck of it's here, and the proximal fibula is here, and the proximal tibia is here. And as you can see, this is the anatomy parts that indicate left lateral knee. So this is my case study, and I thank you for listening, and have a great day.